Welcome, everyone. Thank you for joining me today. My name is Liz Bancroft. I'm a clinical and counselling psychologist, a late diagnosed autistic woman with multiple chronic illnesses, and a mother to an ADHD born from a 6-year roller coaster IVF journey. So I'd like to begin by acknowledging that the work that I do and this presentation itself was created on Whadjuk Noongar country in Perth, Western Australia, and it's been shared today on Wurundjeri Wurrunga on the mighty Kulin Nation. So I pay my deepest respects to elders past and present and to emerging leaders whose knowledge and cultural strength continue to nourish this land and all who live on it. Interestingly, this presentation was developed during Duran and presented now during Makura. Those are the Noongar seasons marking transition and deep winter. So times of reflection, preparation, and resilience building and fertility. So as someone working in the space of reproductive and emotional health, I also want to pause and reflect on the long-held understandings of fertility within Aboriginal culture. So in Western Australia, Noongar culture, fertility is not just a biological concept. It's deeply connected to the rhythms of the land, the rain, and story. And as we discuss fertility today, we must acknowledge that these enduring and relational understandings that far predate modern systems. So it's with deep gratitude and humility that I acknowledge these truths and commit to holding space for them in this work. So, autistic individuals are 3 times more likely to experience infertility. So, when we consider fertility and reproductive health in autistic women, we need to recognise that there's a number of important medical comorbidities that are now emerging quite clearly in the research literature, and that these can directly affect fertility outcomes and treatment planning and patient wellbeing. So, I'm going to step through some of these key findings now. So autistic women have around double the prevalence of PCOS compared to non-autistic women. Similarly, women with PCOS themselves show an increased likelihood of being autistic, and PCOS also increases the likelihood of having autistic children. So these hormonal pathways, particularly involving elevated androgens, appear to be one significant area of overlap. Emerging studies have also suggested that there's a high incidence of endometriosis in autistic women who often report more severe menstrual pain, irregular cycles, and sensory processing challenges linked to menstruation, which of course can compound stress and impact quality of life during fertility treatment. There's also known connection between the FMR1 gene mutations that are associated with Fragile X syndrome and autism, and premature ovarian failure, which contributes to early menopause and can severely limit fertility windows. Then there's population level research, which has found correlations between maternal hormone levels, such as AMH and FSH, and rising rates of autism diagnosis in offspring, though this is still an emerging area of study. We also see strong associations between maternal hypothyroidism and elevated autism risk in children. Similarly, there's maternal autoimmune conditions, including celiac disease, type 1 diabetes, and rheumatoid arthritis that are linked to increased autism prevalence in offspring. So these immune-mediated pathways may also contribute to subfertility and pregnancy complications. And then finally, there's a history of miscarriage, which is independently associated with an increased likelihood of having an autistic child, suggesting that underlying immune, hormonal, or genetic factors may be contributing both to miscarriage risk and neurodevelopmental outcomes. So when you take that all together, what this shows is that autistic women face a higher burden of reproductive health risks, spanning hormonal, immune, genetic, and gynecological domains, all of which impact both their fertility journey and their mental health during treatment. So it's absolutely critical that clinicians move away from outdated stereotypes that autism is purely a neurodevelopmental or social difference, because what the data clearly tells us is that it's very much a whole body condition with medical and reproductive health implications that we need to proactively screen for and manage in this population. So it kind of goes back to what Monique's touched on yesterday. We should also be aware of the emerging research around ADHD and its intersection with reproductive health, particularly medical conditions that may contribute to infertility. Although this is still an evolving field, here's what the current evidence suggests. So, with polycystic ovarian syndrome, there's clear evidence that women are more likely to have co-occurring ADHD. So there's a study that found women with PCOS were about 1.5 times more likely to be diagnosed with ADHD. And another European Journal of Endocrinology study found significantly elevated ADHD symptoms in this population. So given that there's a strong link between PCOS and infertility, this co-occurrence is clinically relevant. Direct research is more limited with endometriosis, but we know that endo and ADHD are associated with chronic pain and cognitive challenges, suggesting that there's a possible overlapping mechanism that can have impact on reproductive health and treatment adherence. And then there's also emerging research suggesting potential shared autoimmune pathways between ADHD and thyroid disorders. So diseases such as Hashimoto's is a well-established risk factor for infertility, and it may be more common in women with ADHD, though there's more direct evidence that needs to develop. And then more broadly, individuals with ADHD appear to have a higher risk of developing autoimmune conditions, and many of these are known to contribute to infertility. And finally, there's several of the conditions linked to ADHD, including PCOS and thyroid dysfunction. They themselves are associated with high miscarriage risk. So while we don't yet have strong direct evidence linking ADHD to miscarriage, these shared pathways suggest an indirect connection that is important for clinicians to be aware of. So before we even layer on the demands of IVF, neurodivergent women already carry a heavier mental health burden. So in the general IVF population, clinically significant anxiety affects about 50% of patients and depression about 40%. And then up to a third meet PTSD criteria after a failed cycle. But for autistic women, baseline anxiety can reach up to 70% with comparable rates of depression and a 2 to 3-fold increase in interpersonal trauma exposure. And then the physical comorbidities compound the distress. So one study found 85% of autistic women reported severe dysmenorrhea pain compared to 28% of neurotypicals. So this is a critical consideration when we prescribe hormonal stimulation. And then ADHD women show parallel vulnerabilities. So sleep deprivation, which is already common in ADHD, is magnified by IVF's nightly injections and early morning blood draws. So that fuels the emotional dysregulation. And then hormone-linked PMDD affects nearly half of ADHD women and an astonishing 92% of autistic women versus roughly 11% of neurotypical controls. So then when you add IVF's physiological stress, you have a perfect storm for mental health decompensation. So this data underscores why neuroaffirming trauma-informed scaffolding is not optional, but it's essential for clinical practice. So we know that IVF is a prolonged state of threat for neurodivergent individuals, sensory sensitivities, prior healthcare trauma, and loss of predictability. They amplify stress responses. And there was a study last year by Zanatoulis et al. That shows that chronic stress in particular impacts egg retrieval outcomes and embryo transfer outcomes. And IVF often triggers existing trauma leading to shutdown, hypervigilance, or dissociation. So if we use the polyvagal ladder as a framework, we can better understand these autonomic shifts and how to support clients towards greater stability. So traditional fertility counselling tends to be reactive. It focuses on supporting clients once they're already in crisis or distress. And for neurodivergent clients, this is often too little too late. So clinicians frequently overlook the need for sensory and communication adaptations and common neurodivergent coping strategies like deep information seeking, scripting, or temporary shutdown. Those are too often pathologized. What's also missing is adequate preparation for trauma triggers within medical environments. So, for many autistic clients, IVF clinics can be profoundly dysregulating spaces, both physically and emotionally. And without intentional scaffolding, these clients are at risk of re traumatization and treatment dropout. So, affirming trauma informed fertility support must be proactive, collaborative, and respectful of neurodivergent ways of coping and processing. So, it was all of this gap that led to the creation of Hope Affirm Thrive, which is my 8-week roadmap online group program specifically designed for neurodivergent individuals navigating fertility treatment. So the program integrates EMDR, DBT skills, schema therapy, and resource therapy, and it's all delivered through a flexible neuroaffirming accessible modules and optional live Q&As and a full-day EMDR intensive. So we target common schemas, things like defectiveness, failure, subjugation, and we help clients process trauma and build skills in emotional regulation, advocacy and boundary setting, and sensory recovery. And importantly, this isn't about fixing neurodivergence, it's about scaffolding resilience, protecting psychological well-being, and supporting physiological readiness, because trauma processing can measurably impact biological outcomes, as we know from the Silver et al. Study. So, affirming trauma-informed fertility care, as you can see, is not an optional extra. It is an ethical imperative. So, when we adapt care to neurodivergent needs, we improve outcomes, we improve engagement in treatment, and potentially treatment success. So, programs like mine show that this is a scalable and achievable. So, if I go back, if I tell you a little bit about my early outcomes in my one-on-one work using this model, I found that there's been significant reductions in trauma and stress and improved confidence in navigating fertility care as well. And then in addition to that, 3 out of 5 of my case studies are currently pregnant. 1 has made the healthy, proactive decision to now cease treatment. And then the last has just completed another round of egg collection after 6 years of treatment and failure. And for the first time has approximately doubled her egg collection rate and doubled her fertilization rates. And that's at 44 years old. So basically, to help you guys, I have created a free downloadable resource that will help clinicians start by co-creating sensory prep plans, validating neurodivergent coping, and scaffolding post-IVF procedure recovery. And so you can also support clients with referrals to adjunct supports like my Hope Affirm Thrive program. They can provide essential in-between session scaffolding along with your one-on-one therapy. So if you'd like to explore referring clients or integrating these principles into your own practice, please connect with me. Referrals are welcome at any stage of IVF treatment. And thank you very much for your time and for your commitment to safer and more inclusive reproductive care.